Hey guys, welcome to this pharmacology review on the drug class atypical antidepressants. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from the what to the why. Having been in academia and practice as a nurse, a pharmacist, and physician for 30 years, I've seen that the antidepressants have grown, and not only the number of antidepressants, but also the subclasses. Well, that gives us more options for our patients so that we can help them. It also reaches beyond the traditional indications of just depression. The problem here is, now we have to pick, well, which drug do I use from which class? And so that is why when we learn things at a level of understanding, we can then turn some of these decisions from being complicated into much clearer decisions, and that's what we're going to do here. Okay, let's take a moment and stop and talk about why we think it's important to study this class of antidepressants. Yes, they can be used by themselves for major depressive disorder, but they can also serve as adjuncts to SSRI-based therapy. It's nice to be able to manipulate another neurotransmitter or go after a particular target where patients may not fit a perfect profile. So these drugs have unique targets, they have unique side effect profiles, and some history that at least gives us that comfort when we're managing other medical conditions. So what are some of the names that are of these drugs that make up atypical antidepressants, and what are some of the common indications for their use? Now we'll be focusing primarily on the generic names. That's what board exams use, that's what most people in clinical practice know them as, but it's also important to just have a vague understanding of even the history. Some of these drug and brand names have been removed. Some drugs we don't even see used in other parts of the world, like Vilazodone. So let's jump into that by looking at this table. Obviously, this table is quite busy for many of you who are, watching this online. If you're listening, I'll walk you through the content, so it's okay. But this table, as well as many others that we use in this lecture and other lectures, are available for those who have part of our free membership at thisiswhy.health. We have collections, playlists, tools like this that you can download for studying or for using or sharing with others to help them apply the information to their patients, okay? So it's for educational purposes, but it's available at thisiswhy.health. Now, let me orient you to some of the information. Each row represents one of the atypical antidepressants. Now, you won't see Vilazodone in this table. I chose very strategically to not include it. Quite honestly, I've never seen it in many years. It's just fallen off, right? The brand name product is no longer made. Most countries and other places around the world basically don't allow it to be used. Why? Liver toxicity. And we have so many other options, we don't need to go to this medication. So I've chosen to not include it for that purpose. You might still see the random rare patient on it, because that's what worked for them, but fine. But mainly the issue is its liver toxicity profile. So each row represents an atypical antidepressant. You see on top we have Bupropion, the second one was Mirtazapine, then we move on to Trazodone, and then Vilazodone and Vortioxetine being the last. And again, I put in smaller font and parentheses some of the brand names that are historically associated with it, recognizing that some of these names are no longer made or available in the United States. That's okay. Again, it's context, it's historical perspective, especially if you read other sources of information, depending on when it was published, they may talk about them in their brand name versions. Sometimes your patients still know them that way. So I just put it there for that reason. So don't let it get too bent out of shape if it's not available. The second column reflects the neurotransmitters that they are trying to mainly target. Again, I try to put these together side by side so that you could sort of see what makes them similar, what makes them different. Some impact dopamine, some impact norepinephrine, some impact serotonin. Some do a combination thereof. And then there's sort of these other targets, is that third column. Other targets can be other receptors, other enzymes potentially, but most of them are other receptors. And the atypicals not only target a neurotransmitter, but many times will reach over and grab and interact with another receptor profile. We see this with some of the other options like Vilazodone and Vortioxetine, which impact some of the other serotonin receptors. So you get some of this partial antagonism, you sort of get some of this partial reuptake inhibition. All of these different effects occur. Mirtazapine works totally different than everybody else, right? It's a presynaptic alpha-2 agonist, and it works to increase the release and excretion of neurotransmitters, particularly norepinephrine and serotonin. That's very different than its counterpart, clonidine, guanfacine, which are alpha-2 antagonists used in the management of hypertension or, in some cases, ADHD and formulations that are designated for it. So I wanted you to see that there's the neurotransmitter target, and then there are the other targets. Those are the things that help to separate them. The fourth column represents the mechanism of action. And again, these drugs are targeting specific systems. We're going to take a moment now and just dive into what is going on in the central nervous system, specifically as axons and neurons interact with each other, and what is happening at the synaptic cleft with these agents as a class and as a whole, because it's very similar. It's just, that's why you just need to know what the targets are at some level, and maybe a subtle effect like the mirtazapine being unique with a presynaptic alpha-2 agonist activity. Okay, as it relates to the mechanism of action of antidepressants, we're going to just think about it as a class, a category. There's a lot of things happening in the central nervous system. There's a lot of nerve fibers that are talking to each other in different tracts in different regions of the brain. And this is part of the reason why some drugs, when they modulate the activity of one track, we see a benefit or an effect in a certain type of condition, but if we isolate that effect in another track, we don't see the same. So that gives us some variability, and that's why you see some indication variation inside of the drug classes of the category of antidepressants. So for example, SNRIs and TCAs, which mechanistically are similar, can treat some pain syndromes. You see that common shared thing, whereas SSRIs, selective serotonin reuptake inhibitors, we're not using it to treat pain. It's mostly anxiety, depressive disorders, those kind of things. And so let's step into what's going on inside of the brain at the central nervous system where these drugs are working. So what we see over here are two neurons interacting, okay, and then they usually communicate obviously by an axon, and in between their connection points is a synapse, or synaptic cleft is what we refer that to. So this picture that we're looking at larger is kind of zoomed in on this region right here. We have the presynaptic neuron where the impulse is coming down from the axon. It then facilitates intracellular and chemical reaction that facilitates the emptying or the release of neurotransmitters. So you see these vesicles that are floating around in the presynaptic neuron, and those vesicles are holding on to neurotransmitters, and those neurotransmitters are the serotonin, norepinephrine. It can also include dopamine, okay? And so we have different vesicles for different neurotransmitters. This drawing a diagram doesn't necessarily reflect the difference in those, but just recognize that those are the neurotransmitters housed in that. Well, you see that calcium is necessary, its influx in, facilitates the binding and the merging of the vesicle at the presynaptic neuron to empty those neurotransmitters into the synaptic cleft. What's the purpose? To then stimulate the postsynaptic neuron that's going to drive the impulse to the next neuron as it propagates through the system. Now, you see on the postsynaptic neuron in the synaptic cleft there's a number of receptors, and these are receptors that drugs can bind to directly. So we have some drugs that act as agonists to these receptors, and you see that these neurotransmitters get in and then they turn on and create the propagation of the nerve impulse moving forward through a number of different mechanisms. There's a lot of different types of transporters here, okay? Now, when these neurotransmitters get released into the synaptic cleft, yes, they can bind to these transporters and turn on and propagate the nerve impulse, but they can also be taken back up by the presynaptic neuron. So that's where reuptake occurs. So when we think about these SSRIs, serotonin selective reuptake inhibitors, those drugs would prevent the reuptake of serotonin neurotransmitters. Well, what would that do? That would leave more serotonin neurotransmitters present in the synaptic cleft to exert more of a pharmacologic effect on the postsynaptic neuron. So you can have, the release of it and then the reuptake of it. There are enzymes present that are not seen here, but there are enzymes present in the synaptic cleft that can metabolize or degrade the neurotransmitters, make them go away, right? So you can take it up and take them away. You can metabolize them and take them away. Or they could go in and bind to the receptor and be occupied and are no longer in the synaptic cleft. Lastly, we do have other presynaptic receptors that are not seen here, but let's just envision like there's an alpha-2 receptor presynaptically up here. Well, there's drugs like Mirtazapine that functions as an alpha-2 antagonist, okay, that is, and the antagonism of that actually increases the release of neurotransmitters. So some drugs work to facilitate the release of neurotransmitters, some drugs block the transporter uptake, and some drugs like monoamine oxidase inhibitors block the metabolism of neurotransmitters found in the synaptic cleft. If you co-administer multiple antidepressants, that is when we can see an accumulation of neurotransmitters in the synaptic cleft that raise the concentration so high that patients now can experience greater risk of side effects. It doesn't mean they all will. Sometimes we do use augmentation or adjunct therapy with dual antidepressants from different classes to manipulate the concentrations of neurotransmitters, but it does increase, obviously, the side effects. When we think about the monoamine oxidase inhibitors, that's an enzyme. And monoamine oxidase metabolizes several neurotransmitters in the brain. So let's go back to the synaptic cleft. If I block monoamine oxidase that's present out here, then these neurotransmitters can be present at much higher concentrations. Well, the thing that's about monoamine oxidase inhibitors is it's irreversible inhibition. For the life of that enzyme, it's gone. So the body has to make more monoamine oxidase enzyme before it can come in here and start to metabolize that more effectively. That's the reason why we have to wait 14 days after stopping the monoamine oxidase inhibitor before starting another class of antidepressants. If we don't, then that enzyme is not working and we increase the concentration in the synaptic cleft that's going to exert a more noticeable effect by those neurotransmitters. That could be good, could be bad. In this case with monoamine oxidase, we do not recommend doing that. But that makes sense of why we need to wait a period of time. Think about antidepressants and you're going to switch to a different class, like monoamine oxidase. You wait 7 days. You want to make sure that drug is gone, especially with high-risk medicines. Now again, some medications can be used in augmentation on purpose, but that's usually done by specialists and in careful scenarios. But we do want to watch out for that because of risks of things like serotonin syndrome and other things. You can lower the seizure threshold. Any drug that increases norepinephrine in the synaptic cleft is known to lower the seizure threshold. And so when you look at things like drugs like Bupropion, right, even venlafaxine, desvenlafaxine, that are going to raise that norepinephrine up as well. Tramadol, which has some SNRI-like activities. All of those drugs modulate, influence the neurotransmitters present. So when we study the drug classes inside the category of antidepressants, we need to have this frame of reference. Are we increasing the release, like Mirtazapine is doing? Are we preventing the reuptake, like SNRIs, SSRIs, right, tricyclics? Or are we blocking the metabolism of the neurotransmitters like our monoamine oxidase inhibitors? So I hope that overview made sense of the mechanism, especially when you just kind of keep that picture in mind. So when you look at these targets, neurotransmitters and receptors, that's all we're doing is modulating them. I mean, I'm going to be honest with you, psychiatry is a very difficult, it's kind of like oncology, it's just difficult because things are not perfect or clean, right? We have a lot of other drugs and other classes that are much easier to wrap our minds around. We give this, we do this, and it exerts its effect and we can measure it. The brain is not that way. There's a lot of circuits that talk to one another. And so having that framework and that perspective can help you make sense of these mechanisms. So bupropion is unique in its norepinephrine and dopamine. Now the norepinephrine part can be bad. Too much of that can be stimulating. It can also cause anxiety, agitation. We'll get to that in the side effects, some insomnia. If you choose to overdose on it, you can have seizures. So when patients exceed, specifically usually around that 450 milligrams, that's when they really start to see that pushing the limits, seizure threshold being lowered. And if you overdose, the risk of seizure is legitimate. Mirtazapine has that focus on norepinephrine and serotonin, mainly. Okay, and again, it's that presynaptic alpha-2 agonist. Unique. Memorize that. Remember it. Some things we do have to memorize. They are what they are. You just have to memorize those facts and be able to regurgitate them. But it makes sense as we start putting things together why we might pick one agent over another. This drug particularly has some issues with weight gain and causing some sedation. Now, the sedation occurs at lower doses versus the anticholinergic properties like dry mouth, constipation happen at much higher doses, that 40 to 60 milligrams versus 7.5 milligrams. So we use these drugs for patients that maybe need that. Maybe they're depressed, but they need to gain weight, or they're anxious and they need to gain weight. All right? So you use the side effects for your purpose of picking the drug. Right? It guides our therapy. Okay? Trazodone is known to have some sedation, and so many times we use it for sleep, especially in patients who are depressed. Now, the effect on serotonin is dose influenced, okay? And so we'll dive into that. So higher doses are needed for the serotonergic effect, all right? So low doses, it's kind of like TCAs, low dose TCAs, tricyclic antidepressants, we use for neuropathic pain, pain syndromes. But at higher doses, if you want antidepressant properties or effects, you got to go higher doses, which means you got to monitor levels and now see greater risk of side effects. Vortioxetine is fairly well tolerated. Vilazodone also, for the most part, tolerated pretty well. they have less sexual dysfunction. As it relates to sexual dysfunction, specifically from SSRIs, Bupropion, Vilazodone, Vortioxetine can be options to switch patients to. That's how we use this. So that's why this table was developed. That's what it's there for, is to kind of guide you and help you to see the uniques, right? Vilazodone is a 5-HT1, so serotonin 1A partial agonist. You can see that Vortioxetine is also a 5-HT1 agonist, but a partial agonist to 5-HT1B and also 3 and 1D. But then has some antagonistic properties to 5-HT7. So those subtype receptors of serotonin, again, give the uniques of why some patients benefit over the other. It also may boil down to genetics. Receptors are known to be genetically influenced, so we have genetic polymorphisms that influence the binding and interaction, and that's why some drugs work better in one patient over another, and that's why family history can also be a guide. This particular table is just kind of summarizing all the antidepressants by class and their basic clinical use and overall impact from a much higher level. So in the middle here we have the atypical antidepressants, and this data comes from an older study, but it's still relevant, still applicable, where we look at the efficacy where going over 1 in an odds ratio is beneficial towards the patient. And you can see in these agents have some benefit with mild to moderate side effects that for the most part can be used if used in the right patient for that patient's benefit. But you can also see that some of them can be quite costly, okay, especially Vortioxetine and Vilazodone. So if you have to switch somebody to that for, like, again, sexual dysfunction, then that can be part of the problem. So this is just another way of looking at kind of the evidence. What is the story? What is the picture that we're painting about these drugs? Picking them one over the other. I hope that it's slowly starting to come together there as you study all the antidepressants as a whole. All right, so now we need to consider some of the pharmacokinetic considerations of maybe that might also influence the drug. We've been talking a lot about pharmacodynamics, but what about pharmacokinetics? Well, again, this table is organized to help us see an important observation. One is a lot of the antidepressants utilize phase 1 metabolic pathways for their metabolism and elimination. They have relatively good bioavailabilities, easy once-a-day dosing for almost as a class, but they all seem to have some involvement at some level with substrates of phase 1 metabolic pathways. And I've highlighted those for you here, some being substrates of 2C19 like Vilazodone, 2D6 nefazodone, again, which we don't use very much, Trazodone, Vortioxetine, 3A4, you see Trazodone and Vilazodone. 3A4 being inhibited a little bit by nefazodone. That's what this column is about, being an inhibitor of the pathways. And then some that may be a little stronger than normal, like Bupropion. And then we have some inducers. Now, we don't spend a lot of time talking about St. John's wort, but it is known to be an enzyme inducer of the phase 1 pathways. So we don't want to ignore some of these things because they could impact the other medications that the patient could be on. But you see that a lot of these antidepressants and other antipsychotics as a group use cytochrome P450 2D6 for their metabolism. Why does that matter? Well, like a lot of enzymes and receptors, this particular enzyme is subject to genetic polymorphisms that influences the way we metabolize the drug, that influences, therefore, the concentrations that are present in the body, which then can impact the efficacy and also some of the side effect profile that the patients are going to experience. All of those things become relevant to consider. All right, so we now know the drugs. We know their basic, some indications, some of these issues from pharmacokinetics. What are some of the adverse drug events that make up this class, or side effects that we need to think about? And again, I put together a table to help us, just again, a snapshot, because There are a few nuances. You know, this table is not perfect, but it's meant to just sort of see the big picture. Okay, so again, our table, you can see the atypical antidepressants. Each row represents one of the drugs. Again, I excluded Vilazodone on purpose. And then you can see the anticholinergic effects that, especially in our older patient population, would be relevant. These are things like dry mucous membranes, constipation, urinary retention, those kind of things. Next, you see GI effects, mostly nausea, vomiting, maybe a small amount of diarrhea, especially those drugs that impact serotonin. Okay, so you see that down here, those agents. Hypotension, again, that would be relevant at some level for Trazodone. It's antagonizing some of the receptors and target receptors that are known to do that. Insomnia, so that's going to be more drugs that are more excitatory. So I mentioned that with Bupropion being a little bit more excitatory. Vilazodone has that impact, so that's good. That'll keep people awake during the day, whereas Trazodone you want to take at night because it's going to make you sleepy. So that's why sedation in Trazodone is a problem. So we take that at night typically. Remember, the lower doses are going to be more sedation. Higher doses are going to be needed for serotonergic activity for depression. Mirtazapine, as I mentioned, was used for anxious patients. It does cause sedation. Again, we have them typically take it at night. The sedation typically occurs at a lower dose, whereas the anticholinergic properties that you see over here tend to occur at a much higher dose. That 45 to 60 milligrams over here is relevant. Okay. Sexual dysfunction, again, you can see drugs that are somewhat associated with it, some that don't. So Bupropion is one of our classic go-to medicines when patients have that. We can switch them from SSRIs over to Bupropion, and it usually takes that away. You mentioned Vilazodone, Vortioxetine, also having that ability to do that. It doesn't cause it as much compared to SSRI. So these pluses and these minuses are not perfect. They're meant to give some general context of how do they fit, right, compared to other agents. Mirtazapine, remember, is the one that's going to cause the most weight gain. So if that is a problem, you need to gain weight. So maybe it's an oncology patient who's depressed and has lost a lot of weight and needs to have an increase in appetite. Well, Mirtazapine might be a great option for that patient as long as they're not going to need to be sedated. But again, take it at night. It'll help them sleep. So these things are outlined over here that can become important for us to monitor. The GI side effects for Vilazodone is relevant. You see here, high risk one, again, nausea, vomiting, diarrhea, probably related to the serotonin. There's a lot of serotonin in the GI tract. So when we modulate that activity, it can be impacting that. So that's why we see these two down here as being potential culprits. All right, what about warnings, contraindications, things that we really should know from a legal standpoint, but also can translate over to some of our counseling points? Well, all antidepressants have a warning about suicidality. Sometimes when patients can be depressed and be suicidal, but not have enough energy to do anything. So they don't have a real clear plan. They're not motivated, but they would rather be dead, right? They don't want to be alive, unfortunately. This is a very serious problem. We don't want to ignore it. The problem when you initiate antidepressants on patients is sometimes they can get enough energy or pickup. You see that with Bupropion a little bit, that increase in energy, that now they have the energy to carry out something. And this is where having a good relationship, good conversation, having access to resources, support systems become very relevant. So please keep that in mind. The second is, depending on which agent you choose, may influence these warnings, right? Bupropion and seizures. Once you exceed those doses over 450, that's where the seizure threshold is really decreasing. And unfortunately, once they start seizing, these seizures can last for hours, if not days, if you don't deal with it. And obviously, that can cause brain damage. So this can be lethal. We also need to be very careful to avoid Bupropion in someone who's trying to come off of benzodiazepines or going through alcohol withdrawal. Those are two situations that also lowers the seizure threshold and increase the risk of seizures. Again, mirtazapine, we might want to be very careful with the anticholinergic properties in our elderly patients, where the side effects of anticholinergic properties are more pronounced. Again, nifazodone isn't used much, but you have to monitor and consider liver toxicity, especially if somebody has other hepatotoxic drugs on board or is actively drinking. All right, what about drug interactions? Well, drug interactions can be very relevant, especially when you're co-administering with other antidepressants. You're starting to mix, and it can sometimes have synergistic or additive effects on certain neurotransmitters. But it also matters, especially if some drug is impacting enzymes, and that's what monoamine oxidase inhibitors do. Monoamine oxidase is an enzyme that helps to metabolize some of these neurotransmitters. So if you have been on a monoamine oxidase inhibitor, they can last a long time because of their binding. And so when you stop them, you have to wait 14 days before starting another antidepressant. Now, if you are stopping an antidepressant and converting them over from an atypical to monoamine oxidase inhibitors, you should wait at least 7 days after that last antidepressant. The exception would be, always somebody making a mess out of things, is fluoxetine. Fluoxetine or Prozac has a much longer half-life, and so you may have to wait several weeks for that drug to be gone before you start a monoamine oxidase inhibitor. Okay? Now, other drugs that lower the seizure threshold would be warning and concern with bupropion. Things like clozapine. Again, coming off of benzodiazepines. Some of our stimulants, right? Some of those drugs are known to do that. So we just have to be very careful. Bupropion and 2D6 inhibition, we got to be careful if we use co-administer with a TCA. A lot of antidepressants use 2D6 for their metabolism. I showed you that on that chart. So that can become a very relevant sticking point that we don't want to ignore. All right, so now that we've reviewed the side effects, their uses and considerations, why we pick one over the other, what about monitoring? Well, hopefully some of this makes sense, but it may be specific, obviously, to the agent within the atypicals that you use. But for all of them, compliance and their overall mood, because we're treating a mood disorders, makes sense, right? If you're on mirtazapine, you want to check their weight. If you're on bupropion, you might want to check their weight because they may be losing it. Blood pressure, any drug that raises norepinephrine levels can increase that risk. So bupropion can raise the blood pressure. So we want to monitor any changes or new diagnoses that may evolve in their work, time of management of these patients. Now, urine drug screens from a lab standpoint can be falsely negative for amphetamines if you're on bupropion. So that is important to recognize so that you don't accuse somebody of using drugs, especially if they have a contract of some sort. But false positive for amphetamines can be seen with bupropion. If you happen to be taking nifazodone or have a patient who's already been on nifazodone and has been on it and is stable, you need to periodically monitor some of those liver enzymes for that one particular. Okay, so counseling, compliance, knowing that the max effective dose and therapeutic effect may take 6 to 8 weeks. It's important to counsel your patient on this so they do not have unrealistic expectations about when are they going to feel better. Now you might see some earlier benefits like sleep and appetite as early as 2 to 4 weeks. But in general, it's going to take almost 2 months for patients to kind of get out of this bad situation and hopefully respond positively. But if not, they may need a dose adjustment, a titration, or switching another drug, which means you got another 6 to 8 weeks. So this becomes very relevant in managing these patients and counseling them appropriately, and also agent-specific side effects that we've discussed. Okay, I know it's a lot. This class is a little unusual. That's why we call them the atypicals. There's something atypical about them. But when we elevate our medical knowledge to understanding for the goal of improving outcomes, it gets easier. We start to recognize these patterns. We start to see a trend in clinical practice of why we pick one agent over another. So this can take time. It needs to set in. Don't try to memorize everything. Some of it you do have to memorize. But repetition, listening to this lecture multiple times can help you solidify it, especially as you interact and see it used in that way in real-world practice. So, again, at thisiswhy.health, you can bookmark and save certain episodes, playlists, and things like that to make it easier for you to come back to. Okay, so we have a lot of options that treat not only depression, but can treat some other things like smoking cessation. That's what Bupropion can help us with, right? We can get some side effect profiles that are beneficial. Maybe we need some help with sleep or weight gain. That can be used to our advantage and treat the depression at the same time. We can use it as adjuncts very carefully with SSRIs. Yes, some of them modulate the activity of serotonin, but some of them also interact with other subtype receptors. So when we learn why these agents are different, that helps to explain how we see them being used in patients, and I hope you found it to be useful. Please like this and follow us on YouTube, and check us out at thisiswhy.health for new topics and other playlists that may be applicable to your knowledge and needs. Take care.